Question number 38. A large case control study was conducted to assess the relationship between the tampon use and toxic shock syndrome. The odds ratio of the tampon use among the patients with the toxic shock syndrome compared to the healthy subjects was reported to be 5. The 95% confidence interval of 4.7 to 5.2 and a p-value of less than 0.01. The authors concluded that the risk of TSS was approximately 5 times higher in the tampon users. This was based on the assumption that the odds ratio is a good assumption of the relative risk in the study. Odds ratio is a good assumption of the relative risk in this study. Which of the following best supports this assumption? The option of choice among the given options is option Charlie. The incidence of toxic shock syndrome is low. The educational objective of this question is that in a case control study, if the outcome is uncommon in population, the odds ratio is a close approximation of the relative risk, that is rare disease assumption. The odds ratio is a close approximation of the relative risk, that is rare disease assumption. So, relative risk can be calculated in the cohort studies by comparing the risk incidence of the disease among the exposed individuals to the risk of among the unexposed individuals. Cohort studies are potentially costly and time consuming, but the case control studies are relatively inexpensive, less time consuming, and popular for exploring disease associations. However, the relative risk cannot be calculated in the case control studies. As such, studies do not follow the patient over time or measure the disease incidence. The exposure or the odds ratio is a measure of association commonly used in the case control studies. It compares the odds of exposure among the individuals with the disease that is cases to the odds of exposure among the individuals without the disease that are controls. If the disease is rare, low disease prevalence, disease incidence number of the new cases is typically low, and the odds ratio generally approximates the relative risk. This is called as a rare disease assumption. Mathematically, given standard contingency table, the relative risk is equal to A over A plus B divided by C over C plus D, and the odds ratio is equal to AD divided by BC. So when the disease is rare, A and C represent small quantities. Therefore, A is negligible compared to B and C is negligible compared to D. The results is this result in a reasonable mathematical approximation of the relative risk, where relative risk becomes approximately equal to AD over BC, which is equal to odds ratio. Okay, then we have, in addition to the rare disease assumption, odds ratio also approximates the relative risk regardless of the disease incidence. Then the cases and controls used in the study are representative of individuals with or without the disease in the overall population with regard to the exposure of interest. The choice beta, that was the exposure is associated with the disease, it was not the option of choice because uh, the result of study odds ratio is 5 suggests that exposure, that is tampon use, is associated with the disease toxic shock syndrome. However, this disease does not affect the approximation of odds ratio to relative risk. The choice A, D, and E were not the options of choice. That is, the option A was the confidence interval of the odds ratio is narrow. The option D was the odds ratio is highly statistically significant, and the sample size is large. None of them were the option of choice because the p-value less than 0.01 indicates that the odds ratio is statistically significant. A large sample size decreases the p-value for the odds ratio and makes the confidence interval narrower. As a result, the precision of the estimate increases. However, this does not affect the approximation of odds ratio to the relative risk. Then question number 39. A 56 years old man comes to the office due to a 3 month of dyspnea that was initially exertional but has progressively worsened to the point that the patient is now breathless even at rest. He has not had any chest pain, palpitations, syncope, or ankle swelling. The patient has no significant past medical history and takes no medication. He has been smoking a pack of cigarettes daily for the past 30 years and has been drinking alcohol heavily for the past 5 years. Okay. Then we have his mother died of breast cancer at age 57. The patient's temperature is 37.1 degrees Celsius, 98.8 degree Fahrenheit. The blood pressure is 113 by 76 millimeters of mercury, and the pulse is 86 per minute. A third heart sound is heard. A third heart sound is heard on the cardiac auscultation, and there are no murmurs. The chest auscultation indicates basilar crackles. His abdomen is soft with no evidence of ascites. Laboratory studies results are as follows. Hematocrit is 32%, mean corpuscular volume is 101, micrometer cube. The platelets are 60,000. The platelet level is very low. MCV is just elevated to 1 degree. Okay, and hematocrit is low, although low but not very low. So the leukocytes are 6,000 per millimeter cube. Liver function study shows alkaline phosphatase of 44. AST is elevated, that is 180. Although ALT is also elevated, but the ratio of AST to ALT is 2 to 1. The chest X-ray reveals cardiac cell-out enlargement and signs of pulmonary venous congestion. Cardiac cell-out enlargement and the signs of pulmonary venous congestion. Echocardiography shows a dilated left ventricle with an estimated left ventricular ejection fraction of 25%. Coronary angiography reveals no evidence of obstructive coronary artery disease. Which of the following measure is most likely to reverse the patient's heart function? And among the given options, the option of choice is, these are also options. So the option of choice is option A, that is abstinence from the alcohol. Educational objective of this question is complete cessation of alcohol consumption is the mainstay of therapy in the patient with the alcoholic cardiomyopathy and is associated with the improvement or normalization of the left ventricular function over time. So here you can see that the discussion is stating the clinical presentation, dyspnea, third heart sound, bibasilar trickles and low ejection fraction on the echocardiogram is consistent with a decompensated congestive heart failure due to left ventricular systolic dysfunction. In this patient with no evidence of coronary artery disease or angiography, the most likely etiology is dilated cardiomyopathy due to heavy alcohol consumption, macrocytic anemia, mean corpuscular volume of more than 100 more than 100 microcube, thrombocytopenia, more than 2 to 1 ratio, more than 2 ratio 1 ratio of the aspartate aminotransferase AST to alanine aminotransferase which is ALT. The alcoholic cardiomyopathy is a diagnosis of exclusion in the patient with a dilated cardiomyopathy and history of alcohol abuse in home. No other potential cause of cardiomyopathy, for example the coronary artery disease and valvular heart disease, are suspected or identified. The degree of left ventricular dysfunction in the alcoholic cardiomyopathy is directly related to the daily amount and overall duration of the alcohol intake. The primary therapy of such patients is complete abstinence from the alcohol use. The intervention is associated with the improvement or normalization of the left ventricular function over time. Choice beta, that is cessation from cigarette smoking. This was not the option of choice because cigarette smoking is a strong risk factor for the coronary heart disease and smoking cessation should be encouraged in all patients regardless of the presence or absence of coronary artery disease. However, tobacco cessation does not reverse the progression of alcoholic cardiomyopathy. The choice Charlie, Delta and Gamma, none of them were the option of choice because initiation of the ACE inhibitor therapy, initiation of the digoxin therapy or reduction of the salt intake, they were not the option of choice because patient with the alcohol cardiomyopathy should be managed in the same way as the patient with other form of dilated cardiomyopathy, salt and water restriction, diuresis as needed, ACE inhibitors or angiotensin II receptor blockers, beta blockers, mineralocorticoid receptor antagonist and if needed digoxin. However, strict abstinence from the alcohol use remains the mainstay of therapy to reverse or halt the further progression of cardiomyopathy. The choice eta, that is niacin deficiency, can occur with alcoholism, but supplementation has no role in management of the patient with alcoholic cardiomyopathy. The choice F, that is, the choice eta was niacin supplementation, and the choice F, that is prednisone therapy. So prednisolone therapy was not the option of choice because glucocorticoid therapy or prednisolone is occasionally used for the patient with alcoholic hepatitis who have a high discriminant factor, but it has no role in management of alcoholic cardiomyopathy. The next question is question number 40, and in this question they are asking about a 38 years old woman who comes to the office for progressive muscle weakness. So a 38-year-old woman comes to the office with a progressive muscle weakness over the last 6 months. She finds it difficult to climb the stairs and comb her hair, and she is unable to walk even short distances without rest. There is no associated muscle pain. The patient was diagnosed with hypothyroidism a year ago when she started gaining weight and has been taking levothyroxine since then. 4 months ago, she developed acute back pain. X-ray at that time revealed demineralization of the vertebral bone. Temperature is high, 37 degrees Celsius, 98.6 degrees Fahrenheit. Blood pressure is 155 by 100 millimeters of mercury. Pulse is 76 per minute, and respirations are 15 per minute. The BMI is 32 kg per meter square. Physical examination shows facial hirsutism and mild proximal muscle weakness in extremities. The patient's muscles are not tender on palpation. and no fasciculations are noted. Deep tendon reflexes and sensory examinations are normal. The TSH is also normal. Which of the following is the most likely responsible for the patient's muscle weakness? And among the given options, the option of choice is option delta, that is muscle atrophy. Educational objective of this question is over here. That is, myopathy in the Cushing syndrome is characterized by the progressive painless muscle weakness, predominantly involving the proximal muscles. It is due to the direct catabolic effects of the cortisol on the skeletal muscle leading to the muscle atrophy. Now here you can see that in this table, uh, like this table is differential diagnosis of myopathy. So disorder glucocorticoid induced myopathy, progressive proximal muscle weakness and atrophy without pain or tenderness. Lower extremity muscles are more involved. The ESR will be normal and the keratin kinase level is also normal. Then the polymyalgia rheumatica, muscle pain and stiffness in the shoulder and pelvic girdle, tenderness with a decreased range of motion at shoulder, neck and hip, and they respond rapidly to the glucocorticoids, and there will be ESR will be increased while the C-reactive protein level or the keratin kinase level will be normal in the polymyalgia rheumatica. The next question is inflammatory myopathies. The muscle pain, tenderness and proximal muscle weakness will be seen. Skin rash and inflammatory arthritis may also be present. The ESR will be elevated and the keratin kinase level will also be elevated. Then statin induced myopathy. The prominent in statin induced myopathy there will be a prominent muscle weakness with or without proximal muscle pain, with or without weakness. The ESR will be normal while the keratin kinase will be elevated. Then in the case of statin induced myopathy we find rare rhabdomyolysis. Hypothyroid myopathy, it is associated with the muscle pain, cramps and weakness involving the proximal muscles. There will be a delayed deep tendon reflex and myoedema, occasional rhabdomyolysis. Features of hypothyroidism are also present. The ESR level will be normal while the keratin kinase level will be elevated. Now this patient has painless muscle weakness associated with a weight gain, bone loss, hypertension and hirsutism, which is consistent with the hypercortisolism or Cushing syndrome, although it is most commonly due to the exogenous administration of glucocorticoid. Cushing syndrome can also be caused by the ACTH producing pituitary tumor, that is Cushing disease. Ectopic ACTH production, small cell lung cancer or primary adrenal disease. This patient requires further workup, for example urinary or salivary cortisol, plasma ACTH, adrenal brain imaging depends on the results to determine the etiology. Regardless of the etiology, myopathy in the Cushing syndrome is typically characterized by the weakness predominantly involving the proximal muscles and may be severe enough to interfere with the daily activities. It is due to the direct catabolic effects of the cortisol on the skeletal muscle which lead to the muscle atrophy. The glucocorticoid induced muscle atrophy is thought to be mediated by the inhibition of AKT1 and intracellular signaling molecule with a serine threonine kinase activity. Interference of the insulin-like growth factor 1 signaling may also contribute. Furthermore, the glucocorticoids may decrease the muscle cell differentiation and protein synthesis. Then the choice A, that is electrolyte abnormality. This is not the option of choice because the hypokalemia, hypomagnesemia and hypercalcemia can cause muscle weakness and hypocalcemia can cause tetany. However, none of these electrolyte abnormalities would be associated with hirsutism in some patients with a severe hypercortisolism. For example, due to the ectopic ACTH syndrome, hypokalemia can develop due to the partial mineralocorticoid effect of the cortisol and accentuate the muscle weakness. However, the weakness itself is due primarily to the muscle atrophy caused by the glucocorticoids. The choice beta, that is mitochondrial dysfunction. This is not the option of choice because the mitochondria generate the ATP by oxidative phosphorylation. Mitochondrial dysfunction generally involves multiple organs, for example, the nervous system involvement, eye abnormalities. Nervous system abnormalities, the eye abnormalities, and the gastrointestinal manifestations. Isolated myopathy can occur usually occurs but usually present during the childhood or adolescence with a decreased exercise tolerance, muscle weakness, myalgias, and elevated keratin kinase. Those are Charlie and Eta, that is over here. So, motor neuron disease and the muscle inflammation, none of them is the option of choice because the muscle weakness in the motor neuron disease, for example, the amyotrophic lateral sclerosis, may be characterized by the features of upper motor neurons, hyperreflexia and spasticity, or lower motor neurons, that is atrophy and fasciculations dysfunction. Inflammatory myopathies can cause progressive muscle weakness that is usually associated with the myalgias and muscle tenderness. These disorders would not typically cause hypertension, hirsutism, or demineralization of the bones. The choice F, that is over here, the peripheral nerve demyelination. This is not the option of choice because I'm sorry, we are ready. Yep. The chronic inflammatory demyelination polyradiculopathy is an acquired inflammatory disorder characterized by the demyelination of the peripheral nerves and nerve roots. It presents with a progressive symmetric muscle weakness, and is usually associated with a distal sensory loss and diminished deep tendon reflexes. The next question is question number 41. So it is basically the second block if you are following blockwise, because one block contains 40 questions, but it is up to you. So question number 41, that is a 32 years old man comes to the emergency department due to a persistent nose bleeding lasting an hour. Over the past week, he has had several episodes of epistaxis that stopped after prolonged nose pinching. The patient has also noticed more fatigue and skin bruising than usual over the past month. He has not had any recent nasal trauma or upper respiratory tract infection and does not use any intranasal medications. The patient does not use tobacco or alcohol and maintains a vegan diet. The temperature is high, 37.2 degrees Celsius or 99 degrees Fahrenheit. Blood pressure is 130 by 80 millimeters of mercury and pulse is 96 per minute. And respirations are 18 per minute. Physical examination shows dried blood in the right nostril, and no intranasal lesions. No enlarged lymph nodes are present. Lung fields are clear to auscultation and heart sounds are normal. The abdomen is soft and non-tender with no hepatosplenomegaly. Scattered ecchymosis are present on the extremities. The laboratory studies are as follows. Hemoglobin is 7.1 gram per deciliter, that is very low. The platelet count is also very low. The leukocyte count is also kind of low. The coagulation studies shows PT is 20 seconds. Activated PTT is 44 seconds. I guess there is prolongation of PTT, I am not sure, but I think there is prolongation. Plasma fibrinogen is 140 milligram per deciliter. It is lower than the normal quantity, and the leukocyte dehydrogenase LDH level is also high, that is 400 units per liter. Which of the following is the most likely associated with the patient's underlying condition? And the answer of choice among the given options is these are the given options. So the answer of choice is option A, that is atypical promyelocytes in the bone marrow. Educational objective of this question is acute myeloid leukemia, the AML, is most common acute leukemia in the adults and is typically associated with the fatigue and symptoms. It is typically associated with the fatigue and symptoms related to more than equal to one cytopenias. Acute promyelocytic leukemia is a unique form of acute myeloid leukemia that often presents with a life-threatening coagulopathy due to disseminated intravascular coagulation. Then we have it over here, acute myeloid leukemia background, most common adult leukemia, and the median age is 65 years. So in the background we know about the acute myeloid leukemia is that most common adult leukemia and the median age is 65. Manifestations of fatigue is common. Other B symptoms are unusual. Often present with the symptoms from cytopenia. Okay, fatigue, weakness seen in anemia, bleeding and bruising, thrombocytopenia, and infection, that is granulocytopenia. Hepatosplenomegaly and lymphadenopathy are rare, and disseminated intravascular coagulation is also seen if it is acute promyelocytic leukemia. Then lab values will show cytopenias. Leukocytes may be elevated, normal, or may be decreased, and elevated lactate dehydrogenase will also be seen. The peripheral smear will show usually myeloblast with our rods. Diagnosis is bone marrow biopsy. Diagnosis is done by the bone marrow biopsy, usually hypercellular with the myeloid blasts. Then coming to the discussion, so they are saying that this patient with fatigue, prolonged bleeding, and easy bruising has pancytopenia, coagulopathy, and elevated LDH. Pancytopenia, coagulopathy, and elevated lactate dehydrogenase strongly suggesting the acute promyelocytic leukemia, a form of acute myeloid leukemia. The acute myeloid leukemia is a clonal myeloproliferation disorder characterized by the accumulation of blastic or immature myeloid cells in the bone marrow and peripheral blood. Patients often develop fatigue and symptoms related to more than one cytopenias, including the fatigue and weakness, that is anemia, bleeding, bruising, thrombocytopenia, or infection, that is granulocytopenia. Examination may show pallor and ecchymosis, but lymphadenopathy and hepatosplenomegaly are rare. The leukocyte count may be elevated, sometime more than 100,000 per millimeter cube, normal or maybe low. One unique type of AML is acute promyelocytic leukemia or APML. It is characterized by the life-threatening coagulopathy due to the disseminated intravascular coagulation, prolonged PT and activated PTT, and hypofibrinogenemia will also be seen. So I guess PT was also prolonged. In APML, the bone marrow biopsy would reveal atypical promyelocytes. Option beta, that was decreased plasma von Willebrand activity. This was not the option of choice because the von Willebrand disease, an inherited bleeding disorder with factor 8 deficiency, is often asymptomatic but may present with a mucocutaneous bleeding and easy bruising. Platelets are usually normal or mildly, not severely low. Pancytopenia is uncommon, and coagulation studies other than activated PTT should be normal. The choice Charlie, that is, disease decreased serum vitamin B12 level. This is not the option of choice because vitamin B12 is derived from the meat ingestion. Therefore, the patients on the vegan diet are at increased risk of deficiency. The deficiency can cause pancytopenia, but coagulation studies should be normal. The choice delta, that was diffuse blastic lesion on the bone scan. This was not the option of choice because that malignancies that cause blastic lesions may infiltrate the bone marrow. They may infiltrate the bone marrow, resulting in the pancytopenia. Most patients with a diffuse blastic lesion have bone pain. In addition, the coagulopathy is atypical. The choice eta, that is mediastinal mass on chest imaging. This is not the option of choice because Hodgkin lymphoma may cause a mediastinal mass, pancytopenia, and an elevated lactate dehydrogenase level. However, B symptoms, for example, the fever, night sweats, and painless lymphadenopathy, are usually prominent, unlike in this patient. The choice F, that is monoclonal protein on the serum electrophoresis. This is not the option of choice because multiple myeloma is associated with a monoclonal protein on electrophoresis and may sometimes cause pancytopenia. Isolated anemia is most common. However, disseminated intravascular coagulation would be unusual in the patient with a atypical in the patients. I'm sorry, in the would be unusual and the patients typically have bone pain. The next question is, I guess we'll continue the next question in the next session because it's a long question. So until next time, Allah Hafiz, fi amanillah, and take care.